if their test hasn't come back yet.
Yeah, I know they like rearranged basically the hospital floors to make it so that the top floor was the COVID floor. So like to minimize, I guess, contamination to other people.
Yeah, they've done a really good job. I'm pretty partial, but I think it's at least in part because our incident commander is one of the EM docs. So you guys have, maybe if you would have seen if you had tuned into one of Hogan's press conferences, David Marcosi is one of his task force heads, and he's also one of the EM faculty at Maryland, and he's incident commander for the University of Maryland system. So he's been kind of leading the force and making recommendations through his system in terms of surge capacity and what to do. So right now, I don't know what stage of the surge they're activating, but basically different hospitals are offloading each other. So in the spring, downtown campus was offloading PG a fair amount. And now I think the downtown campus is actually sending folks to Laurel because they opened up floor 2. It had previously been freestanding with the inpatient beds closed, I think, and they've opened up some floors to help with COVID patients. And then the Lord Baltimore Hotel has also been taking some basically high risk social situation patients, so folks who are homeless or would be going back to a rehab or some facility where they wouldn't be able to isolate. If they come in and have symptoms, then they'll get a test sent, and then we've been able to transfer some people there for the purposes of quarantining.
That's really good to hear about.
Yeah.
I know a lot of places have had I know there's been some controversy over the problem of COVID and homeless populations in cities that have empty hotels that just
yeah, it's challenging, and I mean, I don't think anyone could say that there's not potential for taking advantage of the system. Obviously, if the word on the street is that hotels are being paid for under certain conditions, obviously you could incentivize people to come up with stories that they wouldn't otherwise. But for me, the risk of having a pandemic spread like wildfire through a vulnerable population far outweighs whatever amount of taxpayer money might get spent on trying to avoid that.
Yeah.
So I think it's the right thing to do, and I'm glad that Maryland's doing it.
Yeah, agreed.
All right, so there's people trickling in. So I'm just gonna do some quick announcements before we get started. I just want to thank everybody for coming out. So before we start, I just want to clear up how things work and what we do. So Dr. Kuhn is obviously going to give a presentation. Afterwards, we're going to release a Google form. The Google form is 1 part quiz, 1 part journal entry. If you get a passing grade on the quiz and complete the journal entries, you'll get a certificate, and that will verify your hours. And I really want you guys to really focus on the questions, the journal questions, because I want you to get the most out of this experience. So really reflect on the answers. Really think when she's presenting, if you know what you'd like about the specialty, maybe what you won't like. Just really try to get the most out of it, and really put something into your answers. I was talking to HPAL, and they said that these answers are really good to start thinking about secondaries for med school. So it's never too early to get started thinking about that and working on that. Also, please subscribe and hit the notifications so you don't miss out any of our sessions. Also, since this is our very first event, we're doing a giveaway. So we're going to be giving away a $20 Amazon gift card. All you have to do is when you get your certificate, after you fill out the Google form, post it on your story, tag us, and then you'll be entered to win it. Finally, also, we'll be putting a link into our email list on our website. Please sign up for that so we can update you on any Shellcast news. that's all in from my end. Without further delay, take it away.
All right. Can you guys all hear me okay? Perfect. Okay. Well, thank you guys so much for letting me come and chat virtually. I know things are kind of weird this year, but it's always exciting to be able to talk to people in training at different stages because I've been there and I want to help everybody else along the way. So my name's Diane Kuhn. I just finished residency at University of Maryland, and I'm headed to a new job at Indiana next month. Where I'll be splitting time between the academic sites and the community. So a little bit about me. I'm from Michigan originally, and the way that you know a true Michigander is if they show you where they're from by putting their hands up. We do the hand map, and you've got to have the lower hand facing one way, the upper hand facing the other, and if anybody does it wrong, they definitely weren't born in Michigan. So that's a true Michigander for you. The upper picture right here is some of my residency classmates, my cohort, a bunch of emergency medicine docs who have now kind of dispersed all over the country, but really good folks who are all fighting the good fight right now with COVID. And then I've got little symbols for all of the various places that I've spent time and money over the years. The top one is the Colonnade, which is kind of a classic Southern building structure at Washington and Lee in Virginia. That's where I went to undergrad. And then I went to Harvard for a PhD. I came back to the Mid-Atlantic for med school, and then crossed over the city in Baltimore to do residency at University of Maryland. So that's how I ended up where I am. And then I've got the three most important people in my life at the bottom, which is my husband, Joe, and my two little ones. Aiden is 2.5 and Aubrey just turned 5 months. And on the rare occasions that I make it out of the hospital and out of the house, I have a few hobbies that involve shopping and playing tennis and baking. So my goal is basically just to try to give you guys a little bit of a picture of what emergency medicine is like and put it on your radar, answer any questions you might have about it, just so that you have a sense as you are applying and as you start in med school, whether it's something that you might be interested in shadowing or potentially a career choice down the road. So I might date myself a little, but does anybody know what show this top picture is from? So this was, I think back in the 90s, ER. So this is Anthony Edwards, and this right here is George Clooney and Noah Wiley. So it's a little bit old school, and they had those telephones that you dial around with a circle and some other artifacts of the 90s, but it's sort of a dramatic presentation of the emergency department, and you can see that on Grey's Anatomy and other shows as well. So you might be thinking that the emergency department is something like these pictures, which is obviously CPR, resuscitation, and then here in the middle, you've got a picture of somebody intubating or putting a breathing tube in somebody's throat. And it does have those moments, and certainly we try to pride ourselves on being resuscitationists and for some of the critical procedures that we do. But I think it's also very important to know if it's something that you're thinking about and something that you would consider for a career, that a lot of emergency medicine is social as well. So this picture of the gentleman on the street is a very normal patient for us to see. We see them multiple times every shift. So some people will say they would never work in the emergency department because they couldn't deal with all the nonsense or BS or whatever they want to phrase it as. And so I think it's really important that if you're thinking about emergency medicine, then you would see a patient like that as a privilege and an opportunity, and not as a burden, because that's something that we see and do all the time as part of our job. And then the last picture is something that we're probably all, unfortunately, all too familiar with now, which is a coronavirus particle. So part of emergency medicine, obviously, in addition to treating COVID patients, is some of the stuff that you see on the news, which is the EMS and triage protocols and systems capacity stuff. A lot of emergency medicine docs get involved in pre-hospital care, as well as mass casualty and disaster stuff as well. So I was mentioning to some of the folks right before we started that uh, Governor Hogan's task force, one of his leads, and the incident commander for the Maryland system is an emergency medicine doc. So here are just a few pictures that hopefully will tell you guys a little bit about what a day in the life is in the emergency department. So the first one, these are not actual patient names. That's not a HIPAA violation. I found it on Google. So unless the Google folks broke some rules, I have just copied it from there. But basically, it's meant to show you when you come into the emergency department or on a lot of other services, you'll hear people talking about the board or the list. And that's basically a list of the active patients in the department or on the service. So in the University of Maryland Emergency Department, we have a couple of different teams. So you usually get situated with the red team or with the blue team, and then you'll have a list of rooms and a list of patients, all of whom have come in with a variety of different complaints. So this would be pretty standard. You see some people with shortness of breath, abdominal pain, nausea and vomiting, head injury, etc. And then the next thing that you'll do after you have a copy of the board or a copy of the list is you would get sign out from the outgoing team. So somebody would tell you about where patients are in their workup and what plan they want to execute for them. And then you take over care of those patients, and you'll also start seeing new patients who come in. So the challenge, moving over to the other side of the screen, is that there are a lot of pots and a lot of things on fire and a lot going on, and your job is to kind of keep things from burning. And some days that's really easy and things are going smoothly and all of your scans are getting done and there aren't really any super sick patients. But then there are other days where everybody needs you all at one time and you feel like you're not doing anything very well and you're mostly just kind of moving from one near disaster to the next. So I think if you enjoy working in a restaurant or being a cook or air traffic control or something like that, that's kind of the vibe of a busy emergency department. And so down here at the bottom, I think are just a few pictures to give you a sense of some of the upsides and downsides to emergency medicine. So on the left is somebody rock climbing. We tend to attract a lot of outdoor enthusiasts, which is because we have a weird schedule, which can be as many days on and as many days off as you want. It's shift work. You're other than maybe a sick call day during the month, when you're off, you're off. Those aren't your patients. You're not receiving calls from them, and you can work 2 weeks out of the month and not work at all the other 2 weeks. So people find that they can go to Colorado for a week. Some people choose to do emergency medicine in a place where they can do a lot of rock climbing or skiing. We definitely attract some hikers and other things. And so I think the flexibility of the schedule is one of the things that really draws people to emergency medicine. But the downside of that is the middle picture, which is Happy New Year, and you can substitute any other holiday in that picture. And that is to say that the emergency department is open 24/7. And that means people are working in the emergency department 24/7. So that means New Year's, birthdays, Christmas, COVID, whatever it is, when other offices close down or are only doing telemedicine, the emergency department is open. And so if you would never want to miss a holiday or would never want to work a Friday night, or you would not want to be the place that's open in the middle of a pandemic, emergency medicine is probably not the right career for you. And then, of course, going along with that, there are some family considerations. I think that's important. Everybody should be thinking about that. You guys are more than just pre-med and medical students. You guys have families and friends and lives and hobbies. And I think figuring out how your career will fit in with your family is always an important question for everybody to ask. For me, I think emergency medicine has made having a family easier because although the work itself is busy and can be stressful, we work fewer hours than a lot of specialties. So a full-time community job is usually about 35 clinical hours a week, and an academic job is oftentimes only 25 or 30 clinical hours a week. So if you compare that to neurosurgery or some of the other specialties, you find that there's a lot more flexibility, and you also can move from nights to days to weekdays and evenings and whatever else fits your life at the moment. And there's a lot of flexibility about moving times or moving locations because you don't have to develop uh, a patient census and maintain it. You can work at one emergency department and then move to a different state and work at another emergency department. So those are some of the good things. So I thought I would talk you guys through just a couple of classic emergency department issues that we see and sort of bread and butter stuff. One is a patient with chest pain. So the way that we think about this in the emergency department is we are most concerned about things that are life-threatening. So even if we don't think that somebody is dying or at risk of dying, we still try to put things that could kill them at the top of our potential causes. And we call the list of potential causes our differential diagnosis. So when we hear chest pain, we worry about the heart and we worry about the lungs because those are the things that keep people breathing and keep blood circulating. So there usually about 5 or 6 causes of chest pain that can kill you. And people will quiz you on those in med school and a little bit in residency. But more importantly, they're the things that you have to know if you ever get called for help on a plane or if you're ever in an emergency department alone at night and somebody comes in with chest pain. So we worry about heart attacks, which we call myocardial infarction. And that's just to say it's the heart tissue or the myocardium that has died, which we say is infarcted or dead tissue. So that's one thing that we worry a lot about. Another thing that we worry about that's a little bit less common is something called pericardial tamponade. So pericardial being around the heart, and tamponade is basically saying that there's a bunch of fluid that's filled up around the heart and it's pressing in to the point that the heart can't fill adequately with blood. So basically you have this bag or pocket of fluid around the heart that's preventing the heart from filling well and preventing it from pumping and circulating blood. So that can be life-threatening as well. And then another cardiovascular danger is an aortic dissection. So that's where the main blood vessel coming out of the heart and circulating blood to the body, the wall of it starts to tear, and blood, instead of filling the aorta inside the vessel, is filling between layers of the wall. So every time your heart beats, you're tearing a portion of the wall off. So we worry about that as well. There's something called a tension pneumothorax, which is essentially the collapse of a lung to the point that air is filling into the chest cavity or the thoracic cavity, and the lung can't inflate because air is filling the cavity outside the lung. And you can create so much pressure and so much tension that it ultimately causes the person to not be circulating oxygen and have a cardiac arrest due to lack of oxygen. And then the other main thing that we worry about with chest pain is a big blood clot blocking the lungs, and we call that a pulmonary embolism. So that is something that can happen anytime you have stasis or basically not a lot of movement of the blood in the body. So you might hear people talk about this in the context of plane flights, or getting up, walk around, make sure you're not sitting for too long, stretch your legs, that type of conversation. And that's particularly true for some high risk populations like pregnant women or folks who've just been in a surgery, because they actually have a hypercoagulable state of their blood, where they're more at risk for blood clots. So we have to be thinking about that, because people can have a cardiac arrest and die fairly quickly if the blood clot is big enough. And then the other somewhat less commonly mentioned thing that can be life-threatening is if your esophagus tears. So if people are throwing up very forcefully, or if they've had some kind of instrumentation in their esophagus that tore a hole through, then they could basically be getting air straight into the thoracic cavity and through the esophagus, and that's really dangerous as well. All of that said, of course, most chest pain isn't a heart attack. So part of the challenge of being an emergency medicine doctor is figuring out how to not spend tons and tons of resources on everybody who comes in and says that they have chest pain, when it could be just that they did a hard workout that morning, or maybe they stretched a muscle wrong, or maybe they have some kind of bruise, or it also could just be something a little bit simpler, like a lung infection and pneumonia or something like that. So figuring out how to sort through all those things and when to spend more money on diagnostic testing is kind of how we walk through those decisions. Okay, so that is sort of classic in the sense of distinguishing dangerous. And then this one, case 2, is tired for a while, or if you want, you can say not feeling like myself, just not feeling very well today. So we get lots of these complaints that are sort of vague and difficult to discern exactly what's different. And so we've got a couple of challenges in the emergency department. And I think the first one is figuring out why somebody came to the emergency department that day. Because if somebody's been tired for 3 months or 6 months or 2 years, they could have come to the emergency department on any day. So one of the questions that we teach medical students and junior residents to ask is, what brought you into the emergency department today? And you find that you get, I think, pretty informative answers to that question. So, for example, when I was a medical student and I talked to a patient for a while who said he'd had a headache for a month or two and came into the emergency department, and I didn't ask him that question. I didn't ask why particularly he came in that day. So I told my resident what was going on, and she came into the room after me and talked to him for a minute and said, "So what brought you in today? Why'd you come in today?" And he said, "Oh, well, ibuprofen was helping my headaches and I ran out of ibuprofen." And so that was a good lesson and a good reminder for me that even though it might seem obvious to you as a doctor, as an aspiring doctor, that that information might be important, a lot of times patients don't know what's important to you. The things that are important to them are not the things that are important to you, and they won't include the information if you don't ask it. So part of being efficient is being able to figure out why somebody came in specifically today, and whether there's any reason that you should distinguish a problem that's been going on for some time, and whether that should worry you today more than other days. And that kind of ties in with the social situation I was describing a couple slides back, with the patients with challenging situations where they're homeless or whether they might be addicted to some kind of substance. A lot of those folks make their way to the emergency department pretty regularly. So you'll see them day in and day out. And a lot of times they just need a sandwich or someplace to lie down, someplace to stay warm. And you have to really pay careful attention that you don't miss a presentation when they've been there every other day for a month and all of a sudden they come in very sick and something's different. So being able to keep your eyes alert and keep your biases in check to know when a patient that you might be frustrated with or who doesn't seem concerning normally has come in and all of a sudden something's different that day. So that's one of the other challenges that we come across a lot in emergency medicine. Okay, so I tried to come up with all of the things that I could put on one slide that would tell you a little bit about the lifestyle in emergency medicine so that you can have a little bit of an inside view and help. I think you should ask this question about every specialty. You should ask people about their hours. You should ask people about their salaries. You should ask people about their lifestyles because you need something that fits with your goals and with your overall life that you want to lead. So I put up the salaries that I found just online. I think these are probably reasonably accurate. There's a lot of variation depending on what practice setting you work in, how many hours you work, whether you do private practice, academics, etc. And the other thing that I would caution you about with these is it's really important to ask what hours people work. So an emergency medicine doctor working 30 or 35 hours a week is really different than an orthopedic surgeon who works 60 hours a week. So just make sure that you know when you're looking at salaries and lifestyle, make sure that you know what's expected of those doctors and how long their days are at the hospital. Do they take call? Do they work overnight? Do they have assistants, et cetera, et cetera? So it definitely can't be boiled down to something quite that simple. The other things that I considered, mainly because I wanted a balance of work and family and time off, and I wanted to be reasonable to the people that I love and not have medicine be the only thing that I did. I thought about psychiatry and dermatology as well. I think both of those, in my mind, were things that I was very interested in, but also things that had a little bit more control of the lifestyle than some of the other specialties. So this is up in the top corner. I pulled this from one of my schedules for the past year. So this is a resident schedule, not an attending schedule. So as an attending, you would not work this many shifts. But basically, you can see some of my shifts were, it says PEDS, so Pediatric Emergency Department. And then there's a few different teams, which are different levels of acuity. So you can see the way that we're doing it right now, and it differs in every department, but we had some shifts during the week that were 8 hours and then some weekend shifts that were 12 hours. And that's pretty standard across departments to have shifts between 8 to 12 hours. No residents in the country can work more than 12 hours in the emergency department. So when you hear about residents working crazy long hours, those are other services. If you're off service in an ICU or on a floor, you might work a call shift that was 24 hours or something like that, but the emergency department shifts are never that long. And then here's a picture in the hot tub. This is a bunch of our residents on a ski trip with a few of our faculty members. I like to think that emergency medicine draws a fairly social group and a lot of people who like to do sporty stuff and outdoorsy stuff. So I think that's fairly characteristic of the personalities that you get in emergency medicine. And then I put little Aiden in here on his second birthday because, again, I saw emergency medicine as being a really good fit for having a family and being able to balance things. I'm actually going to start out in a couple months as a nocturnist. So basically working all night shifts. And then in exchange for doing that, you get a lot more control over which days you work. And most places, including Indiana, also have uh, an hourly premium for night shifts. So you can either choose to get paid more or you can choose to work fewer nights. And so my choice was to work fewer shifts. And so I'll end up only working about 10 shifts a month. So, final advice, I was just trying to think through things that if I could go back in time and tell myself as a pre-med, um, what would I what advice would I give to myself that I don't think I followed very well? And the first one I put is the heart in diastole and systole, so relaxed mode and contracted mode. And this is because I think uh, pre-med and med school necessarily draw some pretty talented, but also some pretty stressed and type A personalities. And I think just remembering to have some period of the day, every day, that's for you to unwind and relax, whether that's watching Netflix, whether that's with a spouse, whether it's um, a shower or a walk or a run or whatever you need to be healthy. I think it's really important to develop those habits early because it doesn't get easier. You can't have the approach that you'll just get through college and then, you know, you'll be in med school and it'll be fine, or you'll just get through med school and then you'll be in residency and it'll be fine, or you'll just get through residency being unhealthy and then, you'll have your job and it'll be fine because there are new stressors at every step. There's always another test, there's always another assessment, there's always another patient or another thing that you could do, and then you'll have kids and you'll have a family and other things. You'll be moving here, moving there for jobs. So I think figuring out how to develop that balance and that period of relaxation is really important to you being happy and successful in the long term. So I've tried to get better at that as I've gone along, and I think I've done a little bit better, just out of necessity because you can't be stressed on high energy for 15 years straight. Um, I think as far as these two little pictures down here, I think it's very important to think about money, but not to be consumed by what specialties pay the most. Like I said, there's a lot to those salaries and a lot to the specialties. So make sure to ask good questions about how much time people spend at work, how much time people spend at home, how much stress they're under, and what their responsibilities are. So, just some of the things that I think are tidbits that I learned over the years, psychiatrists are the most likely to be killed by a patient because they're taking on very high risk patients. Obviously, emergency medicine, you can read the headlines about some of the issues with protective equipment and other things that have been going on. You can't bank on having or not having a global pandemic, but anytime you're in an emergency department, you're kind of on the front lines for whatever might happen. There was the shooting in Las Vegas a few years back, and there was an emergency medicine doc that wrote a pretty good article about how he was triaging people and how he was using breathing machines or ventilators to split equipment to be divided between two patients. So you really can't predict what'll come your way. So you have to think about what kind of situations you want to be in at work, in addition to some of the more superficial stuff. Be nice to people, and that includes yourself. It's very easy to be hard on yourself, as a medical student, as a resident, all along the way, and I think it's important to give yourself a break. Um, Obviously, it's important to get along with people in the hospital. It's super easy when it's 3 a.m. And you've been up all night and you're exhausted to be short with somebody else or for them to be short with you. And I think one of the things that's sort of a work in progress is the improvement of the culture in medicine where people are a little bit more understanding and a little bit nicer to each other. So I think just keeping that in mind and making sure that your generation is continuing the good work of generations before you and making sure that the hospital and the learning environment are positive for everybody. And then I think just having, whether it's a personal mission statement or it's just values that you revisit at every step of the way, making sure that you're thinking about all of the things that make you happy, and all of the things that you need in your life, so that you're not not peer pressured, but you don't feel pressure to do a high prestige specialty or a high paying specialty or go to a prestigious school or any of those things for any of the wrong reasons. It's perfectly okay to do emergency medicine because you like it, not because it's glamorous or you want to be, a cowboy out in the middle of nowhere. Neurosurgery is wonderful if you want to operate on brains, not because you perceive it to be prestigious in some way, because I think, 20, 30 years down the road, it's going to be a lot less important to you what people might think of your career or what people might say about your career, but it's really important how much you enjoy going to work every day. So just trying to keep those things in mind. And that's all I've really got. So I'll open it up. I'm happy to take any questions about myself or about emergency medicine, med school applications, whatever you guys have got.
All right. First of all, Dr. Kuhn, thank you so much. I really enjoyed that presentation. I'm sure everyone else did. Gives us a really good insight into what emergency medicine is like from your perspective. Now we've got some questions from our viewers. So one is from Yak Science, and he wants to know if you have any advice for students applying to emergency medicine programs outside of their state, given COVID restrictions limiting rotations.
Applying to emergency medicine residency programs?
I believe so.
Okay. Oh yeah, just like with the away rotations, I know those have been really challenging. I would say my experience when I was applying was, unfortunately, I think medical students are doing themselves a little bit of a disservice by everybody applying to a lot of programs for residency. So residencies kind of get flooded with applications and they have a hard time figuring out who's just applying lots of places and who's really interested in going to a particular program. So I think particularly in an era where it might not be possible to do an away rotation at a facility, finding a way to let that program know that you truly are interested could help you in getting an interview. So there are informal channels and more formal channels. I think if you have family in the area and you say that in your personal statement or somewhere in your application, I think that's important. I certainly did that. My husband's job required us to be in this area, in the Baltimore area, and we also owned a house at that point. So I said all of those things, and I think that that was important to the programs because it meant to them that I was also invested. Some of the more informal channels are a lot of times medical student clerkship directors or residency program directors will know each other and communicate informally about students. So if you go through your advisor or the clerkship director at your school and let them know that you're super interested in going to Arkansas or California or whatever it is, then they might, through the grapevine, know some folks there and be able to put in a good word to get you an interview just so that you can meet people face to face, because it can be really challenging. I know Maryland, I want to say they get between 1,200 and 1,500 applications, and that's for 12 categorical residency spots. And that's not meant to discourage anyone. It's just meant to show that everyone's applying a ton of places. And so you have to kind of find your best ways to make sure that programs really do know that you're interested, because the best residents are the residents who want to be there. No program is going to be successful with residents who aren't excited to be residents there, and residents won't be happy if it wasn't where they wanted to go. So the best matches really are for everybody to end up at a place that suits their professional goals and their personal life. So I think trying to convey that as best you can.
Great. Thank you. Our next question, and I know we were discussing this before we started the broadcast, but I think a lot of people would be interested in hearing, you got your PhD in government before heading into medical school. So what motivated you to kind of switch directions and start a career in medicine?
Yeah, that's a good question. I think for me, I didn't really have too much of a sense coming out of college about the difference between enjoying college classes and becoming a professional in that area. So I really liked my political science classes in college, but that didn't translate for me into being a professional political scientist, where my job was studying theories of government and just writing and publishing. I wanted to be around people more. I wanted to interact with people more. And it just ended up feeling a little bit more abstract than I wanted. And so I still like the academics, and that's why I end up deciding on an academic job. But I wanted some more tangible component of helping people or trying to do some good in the world in my own small way. And I think the clinical portion of medicine provided that, because you get a lot of micro interactions with people on an everyday basis, and I didn't get that in political science.
Great. All right. And our next question is, what types of clinical experience do you think helped you most along your path to emergency medicine before you started medical school? And then what made you decide to pursue emergency medicine as opposed to some other paths?
I think for me, I did things a little bit backwards as far as clinical experience. I pretty much decided I wanted to go to med school, and then I went back and checked the boxes of getting volunteer experience. So there's nothing wrong with that way. If you have either some family members in the medical field or other people, and you feel pretty confident about the choice, and you kind of make the choice and then go back and do volunteer work to make sure, I think that's fine. I've heard a lot of people being scribes before med school and have said that that has been extremely helpful, and it strikes me that it would be a very helpful job to have, just because in addition to making a little bit of money, you're basically the doctor's shadow. So you kind of follow around with the doctor and you learn all of the terminology, and you get to kind of move through their day and understand what they do. And they also have to dictate their decision making to you so that you can write the chart. So you get to understand how they're going about a process and how they're making decisions. And the other nice thing is med school can be really busy, and it can be hard to shadow all of the things you might be interested in. But as a scribe, you could work in an emergency department for a few months or whatever period you wanted. And then if you find that you disliked something or you liked something and you wanted to try another field, you could work as a scribe for an outpatient office or a surgeon or something else. And you can get a little bit of shadowing and a little bit of experience in the different fields that way. So I think that that's probably something that would both help you be successful in med school and give you a little bit of exposure to different fields before you start. And then as far as choosing emergency medicine, I really like going to work and having no idea what's going to happen that day, because some days you go into work and there's really nothing to do. And depending on which job you take, if you take a job in a quiet rural community, there might be more of those than if you work in a busy department. And, people are pretty laid back. If there's nothing to do, there's nothing to do. We're perfectly good at reading the newspaper online or shopping online or whatever else it is. So it's not like I think some investment banking and other places, people are basically trying to look busy and never look like they're not doing anything. And that's not true in the emergency department. We're always happy to have a moment of quiet. But then, of course, there are other days where you go in and everything's on fire and every hand is needed, and you kind of just jump in and you end up starting early and staying after your shift. And I like the unpredictability. And I don't think everybody does, but that was a big thing that stuck out to me, is being able to not take work home, but also not know what was going to go on every time I went to work. The idea of going into work every day and having a 9 o'clock meeting and a 10 o'clock appointment and a bunch of things on my calendar sounded really boring to me. And truthfully, I didn't want a 9 to 5. Emergency medicine felt like a perpetual part-time job to me because I can request a week off here or a month off there, or to work this evening and not that day. And as much as some people really feel strongly about having nights and weekends off, I really love my Tuesday afternoons off or my Thursday mornings off, because I could take my kids to doctor's appointments and I can have lunch with my husband and I can do a lot of other things that folks who might be in the OR or have a busy clinic schedule aren't able to do. So that to me was a positive and not a negative.
Just a tangent off those two questions, Dr. Kuhn. As an emergency medicine physician, do you have any advice to someone like an undergrad student that would want to get involved in scribing at an emergency room? I know because of the unpredictability, it's hard to just jump in as someone that doesn't entirely know what they're doing at first. So do you have any advice to students who would want to scribe and get some exposure in that specialty?
Yeah, I would say so. There are probably more and less formal channels. So a more formal channel would be something like a scribe company like Scribe America. I don't know if that is the company that staffs the BWMC emergency department, but they have scribes that work with all of their doctors and with all of their PAs. And then I know for folks who live further in the city or north of the city, Upper Chesapeake also has scribes in their emergency department. So you could probably look into which companies work there. But the other thing that I would say is that most doctors are really open to having people shadow or work with them. So especially as a medical student, if you're interested in coming, they would be more than happy to kind of talk you through their decision making. And if you wanted to write notes or try to scribe a note while you were in a patient room, I think people would be thrilled to have you and to help walk you through what they were doing. So if you wanted to do it as a job, I'd check out one of the scribe companies. And if you were just doing it on a more casual basis, it might be worth just reaching out to individual doctors or folks who work in the department.
Great. And so, Dr. Kuhn, your path to medicine and to where you are now is a bit unique. If you were to go back and start the whole process over, would you change anything, or would you still go along that poli-sci and government route and then go back to medicine, or would you just do a direct route? What would you change, or what wouldn't you change?
I would try to combine the PhD and MD so I could get med school paid for, rather than being a poor graduate student and then a poor med student. But in all seriousness, I think it was fine. I mean, I think taking time for your other interests, whatever they are, is really important. And whether you take a gap year before med school, or you take a gap year in med school or after med school, or it's just you take advantage of spring breaks and holidays to do things that you love and do things that you're interested in. You don't want to go 10 years or 15 years training to be a doctor and feel like you missed out on something, because you don't get those opportunities back. So when your friends get married, find a way to be there. And, if there's a family reunion or a holiday or a trip to Europe or whatever it is, do it. I mean, to the extent that it's affordable and you can find a way, don't let being a medical trainee get in the way of the rest of your life, because it's really important to do all those things. I think the kind of being a graduate student and getting to do a lot of international travel and backpacking and other things has helped me to get to my 30s and now finally out of residency and not feel like I've missed out on anything at all, because I still feel like I got to do all of the things that I wanted to at every stage, and not that I was kind of stuck in a library making sacrifices all the time.
Great. And now, the whole reason we're here right now is because of the whole coronavirus pandemic. That's why we kind of shifted to this virtual environment. In emergency medicine, you can't really shift to a virtual environment and still treat patients, or at least that effectively. So what was your experience as an emergency medicine physician, kind of as everything started to fall apart, and what adjustments do you guys have to make to keep yourself safe, but also to still treat patients, because emergencies don't go away?
Yeah, that is a great question. Very, very dynamic. So as we were in March, I was pregnant at the time. So I was in our trauma ICU on an off service rotation, and somehow through the grapevine, it got decided that our trauma ICU was that floor was going to house patients who were under investigation for COVID. And that was kind of at the very early stages where things were changing on an everyday basis. So the first step before there were any rules about pregnancy or anything else was that my fellow on the other half of the floor was basically going to cover any patients for me who were at risk for COVID, just because nobody knew about how risky it was in pregnancy. So essentially, it was kind of everybody trying to help each other out. And then there was a lot of training on donning and doffing PPE. So we all hear about sort of the casual mask wearing and social distancing and everything. But when we're doing high risk stuff like intubations and up close caring for patients with COVID, we obviously wear a lot more gear. And so learning how to put that on properly without contaminating yourself, and also how to take it off properly without contaminating yourself, is pretty important. And learning to do that and not rush into a room when you normally would. If you see someone starting to get sick or starting to need something, learning to, I guess the EMS terminology is securing the scene, but that also means making sure things are safe for yourself. So it's everybody's intuition to kind of jump in and try to help, but learning that you need to be safe first, and you need to put on your equipment first and take it off safely, and all those things, I think was kind of a learning process for everybody. And then I think throughout the year, after University of Maryland developed a policy for not seeing PUIs in pregnancy, I ended up doing telemedicine triage for a while. So I was not actually physically seeing patients in the department, but I would help with triage screening and writing notes that way. And then when I came back after my maternity leave and I was in the department again, I think at that point I was seeing everybody, and it was actually a great experience in some ways, because there was a rule that the older attendings, so over 60, were not supposed to be in rooms for high risk procedures like intubation. So it was the first time as a resident that I was actually getting to intubate and do other things without an attending in the room, because normally there's somebody kind of right by your side the whole time until you're out of residency. And so it was, I think, a really good experience to have as a resident, to be the only one in the room with the monitors, with the nurses, making the call to push meds and do all those things. And certainly I wouldn't wish COVID on anyone or any situation, but I think being able to have that autonomy with the attending watching from the hallway instead of in the room was a really good learning experience. And just seeing everybody, all of the residents come together, helping each other out with sick call shifts when people are forced to isolate or have to stay home after they have a cough or sniffles. And obviously it's going to be a lot harder in the winter too, because all of your normal symptoms. That wouldn't be a big deal any other year. I think the current infection prevention policy is if you have any symptoms at all, that I think you have to be out for like 7 days, which means that other people have to cover your shifts. So seeing everybody reaching out and trying to help each other out, and also all the support from the community and other departments for the emergency room staff has been really inspiring.
All right, I think that's all the time that we have for questions today. Thank you so much, Dr. Kuhn, for your wonderful insight on all of this. We really appreciate you. And thank you all for asking such wonderful questions. Before we end off today, I just wanted to quick plug our little giveaway that we're doing on our Instagram. I'm sure you guys all know what it is, but if not, it's at ShellcastMed on Instagram. I can send it out in the YouTube chat. So basically, we just posted a new post that outlines everything that you need to know for the giveaway. So if you're interested in winning $20 to Amazon, go check that out. And without further ado, Magdi.
Yeah, I want to thank you again, Dr. Kuhn. It was amazing, and I'm so happy that people showed up and took advantage of this opportunity, because you definitely shared some nuggets of wisdom that I don't think you could get anywhere else. So we want to thank you for that. The Google form I sent out, I want you guys to really, again, take your time and answer those questions. It's really important to reflect on what she said, and reflect on your career in medicine and what way you want to take it. So make sure to really focus on those journal entries. We do read them, and we can keep track of them if you ever do want them back. But yeah, make sure to do the quiz, fill out the journal entries to the best of your abilities. We want to thank everybody for coming. Check out our Instagram for updates. And we'll be back with more next week. Again, thank you, Dr. Kuhn.
Thank you, guys.
Happy
Feel
holidays,
free-
Dr.
I know you
Kuhn.
guys have my email, so feel free to pass it out if you guys have questions about med school or emergency medicine or anything that I can help with. I'd be happy to.